Had quite a spectrum of presentations here, but I'd like to maybe just throw a first question to Dr. Yu, who's sitting next to me. Do we know anything about the radiation oncologists who've chosen to practice in these integrated, and also to you, Dr. Williams, is there anything special or different about the radiation oncologists who would choose to be in these kind of integrated practices versus those who might practice elsewhere?
At a risk of being facetious, a lot of times the radiation oncologists who can practice at these integrated practices can print money. I think that they're no more or less qualified than any other radiation oncologist, just that they've chosen to obviously specialize in prostate cancer, but also perhaps be an employee of a urologist who's going to send them a lot of patients and whatever implication that has. I mean, these are fine people. I think they've just made a decision that they're going to prioritize the treatment of prostate cancer.
I'd have to agree with Dr. Yu. I don't think they're less qualified radiation oncologists or urologists themselves. They just engage in the financial arrangements, which in turn increase the self-referral patterns. And at least preliminarily from our data, which is based out of Texas using a robust Medicare sample, we're able to depict that there is an increase in self-referral, but also utilization of radiotherapy, which is independent of the tumor biology itself.
Ralph Flexibaum. So I have a comment and then a question from the colleagues. I disagree that they're fine people. It's clear from the data that both the urologists and the radiation oncologists are putting financial gain ahead of patient decisions. It's clear from the shift in practice, especially given the heat around surgery versus radiotherapy. There are, I suppose, more charitable interpretations, but it's really hard to think of one. So that's my question from the FDA to the FDA colleagues. How will the pending legislation in the bill that's going to provide more money for the NIH, as I understand that this will make it easier to get devices approved, but there was some, now I get this from the New York Times, not a medical journal, but that this may have some deleterious effect on the public.
Yeah, I'm actually not completely sure of all the components that are FDA related, but one of the components that I've heard is to actually separate the Office of In Vitro Diagnostic Devices and Radiologic Health from CDRH. And where that would put radiological health, I'd have no idea. Because I think the issue there in separating the rest of our office from CDRH, I think was to make the in vitro diagnostic test market and community much happier. And like I said, I wouldn't have any idea what it would do to the radiological devices. I think some of the tenets, I think, may help improve device approval. You know, we have a lot of internal programs that are already underway to try to do that. Some of the IDE changes that where if an IDE is rejected on the first go round, the clinical trials coordinator from the office or from the center steps in to see what the issue is and how we can best rectify it. So there's a lot of different programs that are trying to help clinical trials as well as device reviews. You know, the device review time has come down for the 510K devices. You know, we have a statutory time frame of 90 days, but we're actually meeting that and taking a lot less time to review these devices.
Yes, Thomas Farrington from the Prostate Health Education Network. My question is to Dr. Williams. You see more patients being referred to the integrated practices to IMRT now. Have you done any comparative analysis relative to patient outcome?
We specifically just wanted to look at, well, first, treatments for prostate cancer versus observation among integrated practices and non-integrated practices. The second of which, of course, which is useful for today's workshop, is the utilization of expensive technologies, but particularly IMRT, which we were able to identify to be increasingly utilized among integrated practices, which was independent of tumor biology. We didn't look specifically at outcomes and how that may translate into either superior or inferior outcomes. But what we do know with the current evidence today and guidelines is that there's appropriate utilization among those with unfavorable risk prostate cancer, however, inappropriate utilization among those that have favorable risk prostate cancer. So there's both a benefit as well as a harm that is in fact going on among integrated practices.
Yes, I do understand the favorable and unfavorable, but you know, a lot of us in the patient community always had the perspective that there were too many surgeries, and maybe there should have been more radiation treatments. So I wonder if we look at both sides of that picture, what conclusion we'd come up with.
I would have to wholeheartedly agree with that, and that was one of the comments that I made with Dr. Mitchell's paper and the conclusions that were had, and one of the commentaries or editorials, you know, that were written is that we have to take into account patients' perceptions as well as the favorable receipt of radiotherapy. What was lacking, however, was the actual tumor biology and the appropriate utilization. So at least our hope is that with our data, which will hopefully be published shortly, we'll hopefully elucidate, you know, that from a cancer perspective.
Thank you.
Before we move on to the next question, I just want to address a previous point about whether these individuals are good individuals or bad individuals. I'm not going to make a comment on the relative good or bad of individuals, but only to note that human beings are economic animals. We respond to incentives. I am not a clinician like some of the colleagues on this panel. But when we're designing our payment systems, we're always trying to design our payment systems so that the patients can be cared for in the absence of economic incentives. That is the ideal. I think in fee-for-service payment, there has been a lot of research over many, many years that suggests when you pay somebody for doing one thing, then they're going to do more of that thing. And so a lot of health services delivery system reform is really designed to create bundles or packages and episodes of care and different kinds of incentives that provide incentives not just to do more, but to provide the right care and reward good quality care rather than just paying for things. So I think, you know, there becomes probably a line over which it's no longer just responding to economic incentives and it's fraud and abuse. And then on the other side, if you don't pay enough for something, then you have access problems because it's not worth it for somebody to do things. So it's unfortunate but true that decisions about patient care are not always driven by what's in the best interest of the patient, but are driven by the economics of the way human beings operate.
Thanks for that excellent comment. Tina?
Okay, question for Dr. Harsain. Follow up on the economic incentive.
Not a doctor, PhD or otherwise. Although this is where I always love to say I have a son who's a third-year medical student, and I have another son who's going to be a first-year medical student in about a month. So when you talk to Dr. Hartstein, I'm going to be looking around for my sons in a couple of years.
Okay. Yeah, so my question is follow up on the economic incentive. So provider ownership could provide an incentive, but then when you have different reimbursement rate that provide extra incentive for people who want to use like IMRT or proton therapy. So I wonder, like for CMS in deciding how much to pay for external beam versus IMRT, and what we've seen in the literature is IMRT reimbursement was 3 times higher than external beam. So how do you, decide on that payment rate? Yeah.
All right, let's allocate about 3 or 4 hours for this answer. So it depends on what the payment system is. Hospital is a lot easier than physician, or at least in terms of explicit decision-making, because we pretty much just rely on the data that hospitals submit to us as to how to price different technologies. In the physician world, it's a very, very complex methodology, but the idea is to recognize the resource inputs that are associated with doing the service. And our feeling is if we appropriately recognize the resource inputs associated with doing the service, we will get the right relative payment relationships among the services. And this is an ongoing and continuing process. We're always trying to refine and improve the information that we're using to determine payment rates. But again, it comes down to we are trying to achieve an ideal. We're always striving to get to that ideal, but we're never actually getting there.
Lawrence?
Yeah, so I had, I guess, a question maybe and a comment. Maybe I'll make the comment first. One of the important groups who's actually missing on this panel would be the vendors. Sorry, Jay, I'm looking at you on that, because I think a lot of the cost of healthcare is the cost of the equipment, and how does that cost? I guess the difference between cost and charges, what does the equipment actually cost to make versus what the charge is for it being made? And I think maybe when we do this panel again sometime, we'll have a vendor on this committee and comment on that. But the question I wanted to ask was about 510K. This is an area I know nothing about. So I've always been fascinated to know how similar does a device have to be to qualify under a 510K? And in particular, do we know that 5 years from now, that device isn't going to, I think that in the press, there have been issues with, for instance, artificial hips and not lasting as long as they were anticipated to last, that got approved under 510Ks. And so just a little bit more information about what does 510K really mean? How much does it have to be like what the previous device was like in order to qualify, and how do we take account of that?
It has to be substantially similar. There can be technological improvements, but if you go to the FDA's website, to CDRH's website, you'll see what we call in the FDA the flow chart. You have to be able to take your device and the predicate device through each question in the flow chart. That is substantially similar. And there is an issue with the 510K program that's called, I always say it wrong for some reason, feature creep. I always want to switch syllables around there. But that does happen over time. If you look, one of the issues that our division faces with feature creep is a sponsor will come in for, I'll say, a diagnostic X-ray system, and they'll use a predicate from the middle 80s or early 90s. And that usually attracts some of our attention in additional questions for the sponsor.
Do you think a carbon beam would qualify under 510K?
That's actually a good question. We won't know that until we have a regulatory review in front of us, until we have a submission. There are a few that are working their ways to come into us, but at this point in time, we don't have a submission.
It'd be pretty gutsy, I guess, for someone to build a $250 million facility not knowing whether there's going to be a approval for it.
It's what we do, what FDA does with proton accelerators with that, is we allow a manufacturer to start building one of these devices, because we have to get our safety and effectiveness testing from those devices. So we use enforcement discretion to allow them to put one unit in place, and that's the unit they'll test for us.
I actually have a comment on that. So as you look at your 510K, you may want to also make sure you understand your label, because when they come to us and you want to go off your label, we take a very hard look at it. And you also want to look at your underlying evidence for your 510K, because we're looking very closely at that. And sometimes we can't even find the predicate. And so when you go down the 510K route, make sure that you are also thinking, if you want to be in the Medicare realm and you want to talk to the coverage group, make sure you think of payment as well when you go down this road.
Vikram, NIH, and this question is primarily directed to my CMS colleagues. I don't know if you were here this morning when we talked about the differences between device trials and drug trials. Now, drug trials are generally funded by industry, and by the time you make a coverage decision, efficacy data, comparative efficacy data are usually available. Whereas with device trials, it's the other way around. And frequently, and these are not funded by industry by and large. These are, many of them, not enough, but many of them are funded by taxpayers through the NIH. And by the time the trial starts, the device is already in widespread use. So to get to the point, about 15, 20 years ago, it was an article of faith in the radiation oncology community that higher doses of radiation will lead to better patient outcomes. And about 10, 15 years ago, the NIH funded a number of trials to test that hypothesis when these devices like IMRT were already in widespread use or coming into widespread use. So what we have learned since then is that the higher doses benefit some patients and harm other patients. Okay? To take the example of prostate cancer, a trial looking at 70 gray versus 80 gray of radiotherapy has shown that a small proportion of patients benefit, but there is also more toxicity. So my question is, do you have a mechanism 15 years later after the approval that this was regarded as a substantial clinical improvement based upon surrogate endpoints like PSA to revisit that and to refine the indications in terms of which are the patients who are benefiting and which are the patients who are not likely to benefit or be harmed?
So from a coverage perspective, we do. So it certainly is much harder when you've said yes to then move to a no. But I think for us, we certainly have walked down that path where if there is a clear indication that the harm outweighs the benefit, we can revise our coverage determination to narrow it, or maybe to pull it into coverage with evidence development, so that we can either say, okay, it needs to be in a registry or further study. So it is something we can do. It is a lot harder to do because you're narrowing coverage versus expanding coverage. But it has been done and it is possible.
And how does that process get initiated?
Well, I can only speak for the national coverage determination process. We can either initiate it internally, or an outside, anyone can ask for a national coverage determination. And I've had several that have asked us to do a national coverage determination to actually issue a no. Now, we go into it fairly neutral, but anybody can ask for an NCD.
And if nobody does?
Pardon me?
If nobody does?
So CMS doesn't initiate it internally, or well, then there's no NCD at all. It just stays the way it is now.
Yeah, I want to comment on the substantial clinical improvement part of this. So when we're evaluating technologies for substantial clinical improvement, by definition, they're new, so they don't have a lot of evidence. So it's making a determination in the absence of a lot of experience on whether that technology is a substantial clinical improvement or not. And the agency has been highly criticized by the vendors, the device industry, for not approving enough technologies and for having what they call opaque criteria. To which I would respond, we could have precise criteria, but then we'd probably be approving even less because you'd have to meet some statistical test or some very hard and fast criteria rather than us using our judgment. And I've always liked to say there are some things that are very, very easy to see are a substantial clinical improvement, and then there are other things that are not. So the technology that I like to look at, I think it was called Argus 2, and they had a film of a blind person, blind since birth, walking without a stick, without a guide dog, and then stepping up on a curb, and then a patient was walking in, or a person was walking in front of this patient. They were at the beach or something, or on a boardwalk or a sidewalk, and the person stopped. Okay, I'm not a clinician, I don't have, but even I could see, wow, that's a technology that helps a blind person see. I mean, that's pretty cool. That was pretty incredible. as opposed to you're talking about R-squareds and all kinds of statistical concepts where it could be very much a subjective judgment as to whether that's an improvement or not an improvement. So it's not an easy thing to know because there's not a whole lot of evidence out there. Some things are going to be crystal clear, most things are not.
Yeah, I guess this one's for our FDA speakers. Having lived in the 510K world for the last 35 years, two questions, because this was very interesting. I think you made one comment about radiation, and it is true historically. If you've looked at the LINACs, the indication for use is radiation directed anywhere in the body to treat neoplasms as directed by a physician, something like that. And I think in the last couple of years, you'll see that the manufacturers have tried to start getting more specific because it's a real question that the vendors or the manufacturers have for the FDA, where, and this leads into the second part, which is labeling. So for you in the audience here, there's a great debate that goes on, such as the following. If our 510K says, okay, the doctor, this is to be used to treat neoplasms anywhere in the body with radiation as directed by a doctor. But then we decide we're going to put an ad in the Red Journal talking about SRS for brain mets. So that's very, very specific. It is radiation in the body as directed by a physician, but is it too general, and can you actually advertise that? Or using IMRT for prostate, or whatever the technique is that comes under the general umbrella, but you get into the debate internally with our own compliance people as to whether or not, if we want to talk about that in our literature or cite the literature that's actually out there, developed by our peers here, that we have to have a much more specific indication for use. So that's question number one.
When you go from the general to the specific, if we have adequate evidence that the specific utility falls under the general, we're usually fine with it. Usually oncologic applications fall under that realm. Where we start to have more questions are when you're talking about irradiating, specifically irradiating a nuclei in the brain or something like that, with a new use, what we would consider a new use, and then we start to ask for clinical trials and clinical discussion, and a lot of that is a discussion between the vendor and the division.
Yeah, because there's a real world issue, or not issue, real world scenario is when we're talking 510Ks for the LINAC and we're talking to our FDA consultants and whoever, it's a bit gray about what is needed in terms of what specificity if you want to talk about it in your labeling. Interestingly enough, on the treatment planning side of things, their view is, well, you're talking about using this to model radiation anywhere in the body, and therefore, in your literature or even in your training, if you want to use specific examples like the breast or prostate, then it's okay. So there, the general is better. Second question, we get into this as well. So one of our products is basically an EMR for oncology. And we actually 510K that. The reason we 510K that is because there is an electronic interface from the information system to the LINAC. Now, the question I have is as far as I know, if you look elsewhere in healthcare in terms of EMRs, Cerner, Epic, et cetera, they're not 510K'd. What is the FDA's position on nowadays an information system taking on, by the way, the class of the LINAC, in this case, class 3, yet it's an EMR system where other EMR systems, as far as I'm aware, don't require 510K at all?
There's some new guidance that has come out a while ago on software devices. That's one issue to take a look at. And I would encourage you to come to the Division of Radiologic Health with a pre-submission on this question.
Oh, it's a good one. Yeah, we already do it, so I guess we're in. But sometimes we feel like we're at a disadvantage because, as you say, we come out with a new release of software, we go through the whole process. Do we have to go and submit again? Yeah. Okay. Anyway, thanks.
So I have a question for our colleagues from CMS. I've appreciated the decisions that you've made in recent years with regard to the lung cancer screening trial data being implemented and your registry data and so forth. And also, I believe several years ago for CT colonography screening. And in that case, the issue was that the device or the procedure had not been tested in the appropriate target population. I think we have concerns in terms of either looking at surgical devices or sometimes the radiotherapy devices, that whatever evidence is available may not necessarily be in the over 65 population who might use it. Are you going to be more vigorous about looking at that? Because as we know, the vast majority of people who get cancer are older. I'm thinking about now, I work in the area of breast cancer, IMRT, and now even protons are going to be tested in breast cancer therapy. And, will those trials have adequate numbers of older women? And will it be relevant to the CMS population? So I'm just wondering what your views are going forward now on device approval in the appropriate population.
So, and we had a MedCAC along these lines in 2010. So, and I think then when the conclusion of the MedCAC is that the evidence was insufficient. So we certainly are looking at IMRT and proton beam, and I think the evidence is certainly maturing, but I'm not sure it's anywhere near quite where it needs to be. And I think our contractors with their various decisions are you can see that it's unclear out there. But I think it's important that you have our population, whether it's 65 and above, it's the disabled and the ESRD population. And I just the other day was having a meeting with another group, and not specifically on this topic, where I said, okay, if you don't have our population, you're going to have to draw us a map to see how I can generalize the results of your trial to our population with the same characteristics of our population. Because if we can't generalize it, it's hard to make a decision on it. So I think those are the two key points. And we don't want to be necessarily the rate limiting step, but we really do need to see it so that we can make the right decision based on the evidence.
And I think that point raises that distinction between efficacy and effectiveness, where a lot of clinical trials don't incorporate these under 65, and it's a definition of looking at whether a treatment works in a narrow population with a narrow outcome. And I think it's going to be very important to incorporate these novel forms of comparative effectiveness research as a complement to the randomized clinical trials, especially in the elderly population.
When you make coverage with evidence development decisions, I think the kind of evidence we're usually talking about is the development of large registries in which data can be stored and then subsequently analyzed. From a CMS perspective, who do you see as actually paying for this evidence, for these registries? Is it specialty societies? Is it vendors? Where's the money to come from?
So if we do a national coverage determination and we decide that it is coverage with evidence development, then CMS will pay for the device and the routine and related costs. Mm-hmm. Then it's going to be up to whomever to decide how they're going to collect that data. And so in the past, it has been specialty societies, it has been academic centers, it's been a variety of places. So, I mean, I think it's a shared responsibility. The evidence isn't that clear yet, and so this is an opportunity to get it there, and I think we're sharing that responsibility.
Yeah, I have a question. Number one, this session this morning, this afternoon, been fantastic. I've had the opportunity to learn quite a bit. I have one question about your comparative effectiveness studies for radiation therapy. You're comparing X-rays, IMRT with proton. Why isn't SBRT included within that effectiveness study?
So we published an SBRT study comparing, SBRT and IMRT using, I believe it was the Chronic Condition Warehouse. And we found a greater rate of claims-based toxicity. And at the same time, a lot of people have shown equivalent patient-reported outcomes. So that's another wrinkle on this whole idea of comparative effectiveness. I think physician-reported and claims-reported measures of toxicity may be significantly different, while at the same time, patient-reported outcomes may be similar because they're measuring arguably two complementary things. A patient-reported outcome or a health utility measures a patient's quality of life integrated over years, whereas incidental toxicity that happens, for example, urethral stricture and is dilated, and then 6 months later, a patient is asked about their overall health. Those two may be different. And so I think there's multiple layers of evidence that need to come together to evaluate a technology. And then once those levels have come together, there's a very complicated decision-making process that can be aided with decision tools, et cetera. This whole process of choosing a prostate cancer treatment is enormously complex.
Yes, I'm very familiar with that. I've been treated with 3 forms of radiation over 15 years. But in these broader discussions that we're having now, I think SBRT, when you talk about reducing costs, it appears that is the one new technology with a lower cost. But we seem to be focused on proton therapy and IMRT. And I would have loved to seen SBRT included in the discussion.
You've had the last word before our break, so thank you for your contribution. So we have a break now for about 15 minutes. So join us back here at 3:15.